Now we move on to the next session, and I invite our chairperson, Dr. Ganesh Jewalikar, who is principal consultant pediatric endocrinology at Max Healthcare, Saket, New Delhi, and he has won many awards, being second in Mumbai University in MD examination, and also bagging the first prize in quiz at EPIS Fellow School. His areas of interest are diabetes, technology, and classification of youth onset diabetes.
Thank you for that kind introduction. In the last decade or couple of decades, I think one of the biggest advance in the diabetes technology has been continuous glucose monitoring, and I think there can be no two opinions about it. So this session is going to be on CGM and CGM apps, and I'm very happy to invite Associate Professor Ryan Paul to deliberate on this topic. He is from University of Waikato, New Zealand, and also a clinical associate at Morris Wilkins Centre. He is the immediate past president of New Zealand Society of Endocrinology and the executive member of New Zealand Society for Study of Diabetes. His interests include diabetes, in addition to diabetes technology, management of diabetes in youth and emerging adults, and education of diabetes for health professionals. Welcome, Professor Paul. It's his first visit to India, so we're happy to have you here.
And thank you for inviting me. It's been a fantastic trip so far. I brought the whole family, so it's been great. And this is a nice small session today, so please feel free to ask any questions as we go along if you wish. Here are my disclosures. My biggest disclosure is I'm an adult endocrinologist. I've already been asked a couple of times, why are you at this meeting? But I do a lot of work with youth and emerging adults, particularly with those with diabetes between 15 and 25 years of age. And I will say all this content in this presentation is my own opinion. I know many of you have experience with CGM, but it's just tips that I found really useful in dealing with all the common issues or troubleshooting that we have with CGM. So the first case is talking about alarm fatigue. These are all these are all real cases. You may have similar ones in your practice. There's a 14-year-old boy, type 1 diabetes on multiple day injections of insulin, and his HbA1c is 97 or 11%, and he has a strong fear of hypoglycemia. And one thing that CGM is really powerful at helping reduce is fear of hypoglycemia, remembering that many fear is actually rational. It's not irrational. They may have had a severe episode before, and here we have something which can provide that reassurance. It's unusual in New Zealand in that it may be similar in India, but I know it varies around the Pacific, but many of our families have purchased CGM directly from the supplier, and the diabetes teams have been completely unaware, no knowledge at all. And if you use the alarm settings that come out of the box, this is when it can create issues. In fact, for this family, both the mum and her son were just driven crazy. They didn't sleep at night. It was just going off all the time. So they end up silencing all the alarms. That was the one solution. And unfortunately had an episode of severe hypoglycemia 1 week later, which was very preventable, and it's how we can deal with that. So I'm going to go through about alarm fatigue because it really is a major issue in terms of continuous glucose monitoring. In fact, it's also a major benefit. Many people with CGM find the alarms and the rate of change far more beneficial than the actual glucose level itself. So it is, how can you maximize that benefit and minimize that distress? But one thing is, particularly in the teenagers I deal with, many of them will actually rip off the sensor in 1 to 2 days if you don't deal with it. So it's about how we can fix that. So the first thing is actually familiarizing yourself with what alarms are available. And one tricky thing is it does depend on which sensors you have. And I know that it's different in every country in the Pacific as well. And I was just talking to Ganesh now in India, and it's mainly the Freestyle Libre 1 and Pro and the Dexcom G4. So you're really dealing with, it's mainly your threshold alerts. When hopefully that it's not that far away when the newer models become available. But with the G6 and G7, you do have an urgent low alarm, which is 3.1 millimole per litre. You can't change that. Also, there's an urgent low soon alert. So what that means is if your glucose levels are predicted to go below 3.1 in the next 20 minutes, that will also alarm. You'll be familiar with the low and high threshold alerts. The Dexcom G7 and the Dexcom One Plus also have a delayed first high alert. And what that means is you can set a time up to 4 hours before that alarm will go off, which is really helpful after eating. I mean, most of the hyperglycemia we see is after meals. So you can say, look, I'm not going to make the alarm go off to at least 3 hours after eating, so it doesn't annoy me. All sensors will have a loss of signal alert or a technical alert for when to change. And you're probably familiar with the rate of change alerts, for example, with the Guardian 4. So in terms of how we prevent that, I talk to all of my people with diabetes, this is mainly those with type 2 diabetes who aren't on insulin or sulfonylureas, to turn the low alert off. We now know that's very common in people without diabetes for their glucose levels to go between, particularly 3.4 to 4 millimole per litre. It's not meaningful hypoglycemia in 99.9%. Turn it off. The biggest alarm that you can help with is the high threshold alarm. I'll be honest, most of particularly my adults with diabetes, young adults, their HbA1c may be, at best 9%, 10%. We are different to other parts of the world. If they set the alarm, of 10.1 or 180 milligram per deciliter, in most, that will drive them nuts. So I often say, look, why don't you set it at 18 or 20 millimole per litre to start off with, or even think about turning it off initially when they start. But I'll talk more about how we change that with time. Also, if they are on the G7 and One Plus, use the delayed first high alert. Once again, that's only if you have that available. But I think it's really important to change the threshold alerts with time. We're not starting off with an upper alert of 20 saying, that's where we're aiming for, but it's about, you might decide every few weeks or whenever you have contact, hey, I'm going to reduce that down by 2 millimole per litre. At the end, you may get to that upper threshold alarm at 10 to 12, but you bring it down with time so you don't cause significant distress, but you're still getting towards the targets that you're trying to aim for. At the same time, you might have that low threshold alert. You may find that actually I've set it at 4 millimole per litre, but that's actually not stopping the lows. That's still happening. Maybe I actually set it at 5, so I can allow time for action to occur. So that's where you customize it and you change with time as clinically needed. One thing I think is useful, and this does come with most apps, is use different sounds for the different alarms. And, for example, if you've got a toddler, you want to know if they've got an urgent low alert in particular or an urgent low soon alert compared to a high alert. So it's about using those different sounds so the family are aware what alarm is acting, what do I need to do right now to correct the dysglycemia. Other thing I do for people on pumps is actually I consider turning off the CGM alarms altogether, because often the pump alarms will do all the CGM alarms anyway, and the last thing that people want is both the pump and the CGM going off at the same time. But that is really particularly only on those on sensor-augmented pump therapy or automated insulin delivery. If it's not compatible, such as using a Freestyle Libre with a Medtronic pump, please do still keep the CGM alarms on. Loss of signal alarms. So every sensor that you will have a dedicated app to use on a cell phone. There are also a whole lot of apps you can get off the App Store or Google Play, which will go with the sensors, but they will often have difficulties with loss of signal, particularly around on cheaper phones. So the best way around that is using the dedicated app for that sensor. If you can keep the phone or the reader within 6 meters, ideally without obstruction and not through walls, that is handy. For many people are very used to carrying their phones. But for example, if you are taking a child to school, it's actually the school being aware we've only got CGM funded this week. I'll talk more about that. But one challenge is that cell phones are banned in New Zealand in schools, and having to overcome that barrier and making sure all schools are aware so we can have that phone in there. And it also means actually families having a dedicated phone for that child, because that phone needs to go with them when they go to school. They can't often take mum or dad's phone. So it's about overcoming those issues as well. If you do still have trouble with loss of signal, it is about making sure the phone is well charged, and you try and reduce that competition for Bluetooth. I must admit, I'm no technological expert, but one thing you do find is even just turning Bluetooth off and on, if that doesn't work, turn the phone off and on will generally fix most issues. If not, phoning technical support. And I think one thing that's really useful in your practice is setting up clear pathways for your patients and their families when they contact you for help and when they contact technical support. Because many of the issues around CGM and automated insulin delivery are technical, and actually going through the companies is often far more useful than plaguing you with non-clinical queries. So that's alarm fatigue. The other thing which CGM can cause is diabetes distress. And I'll talk about this. A 16-year-old girl with type 1 diabetes, once again on multiple daily injections of insulin. We would only roughly have, in terms of our young adults, only about 20 to 30% on insulin pumps at best, because they've only just become, or in terms of automated insulin delivery, become funded this week. For our children, it's actually about 90% on pumps, and that's because they can receive a different allowance from the government for that. But that stops. So young adults, that's only been this week. But this is one thing that can cause, not only can it cause distress for the person with diabetes, but also the family. And this is where just getting that knowledge of what normal and what to expect with CGM is really important. So all of a sudden they saw the CGM trace, and mum started giving small meals instead of normal meals, trying to get a flat trace. Didn't want to see those rises. And she phoned the daughter, and the daughter was 16. The daughter found this very embarrassing. Whenever the glucose levels were high, she'll get a phone call. Daughter hated that. You can imagine exactly what, as a teenager, how you'd feel about that. She was very overwhelmed. She was very ashamed. In fact, she wanted to switch to a reader. So the standalone readers won't communicate in real time with the follow. So it is one way that many people, particularly teenagers, will choose. That's one way of their parents not being aware. All for those people, we do have a few people in New Zealand with tinfoil hats who have scared a big brother, and who don't want their information necessarily shared in real time. It's where a reader may be useful. Also, the family and the daughter ask, I'm not even eating. Why are my glucose levels going up? Yeah, and that's a really common finding as well. So in terms of just tips that are useful, I found particularly useful in reducing diabetes distress. The biggest one is just setting clear and realistic expectations right from day one. In fact, ideally we'll be using it in people from diagnosis. When they come into hospital the first time, they have a CGM sensor inserted. But what CGM does for the first time is it allows also people to follow. In fact, you can have up 5, 10, the number of followers continues to increase. And in real time, people can be aware of what their glucose levels are. I think it's really important for everyone to know what a normal CGM trace looks like. If you haven't had a chance to wear CGM, I would strongly encourage you to do so, just so you know what it's like. I'm lucky enough not to have diabetes, but I will go up into double figures after breakfast. Every breakfast, doesn't matter what it is. I will shoot right back down, and I'll stay around about 5 for the rest of the day. I will challenge myself with carbs. I'll struggle to get above 6 to 7. But at breakfast, doesn't matter what happens, I'm in double figures. This seems a bit of a misnomer, but I think it's really useful to concentrate on time out of range. So we're aiming for greater than 70% time in range. What that means is you can still spend roughly 6 hours a day out of range. It's normal. It's okay. It's providing that reassurance that there is still a significant amount of time. You don't have to be perfect. You can live a normal life. And on that, I'm really One of my biggest mantras is the importance of lifestyle ruling diabetes and not vice versa. Otherwise, you will get often significant diabetes distress. We've spoken about how individualizing alarm settings can reduce diabetes distress, but also explaining what does all this data mean. Because all of a sudden, for many people, this may be the first time they see their glucose levels. Often they may be checking their glucose levels once or twice a week at best. All of a sudden, it's everything. And how often to review data. And one thing I find quite useful is families sitting down once a week. It's a dedicated time to 5 to 10 minutes, having a look at the time and range and thinking about what are the patterns in the glucose levels, what can we change to make a difference, seeing what works, what doesn't work. It will be, often there's no rhyme or reason in diabetes. I'm sure you're all very familiar with that. But it's thinking, 5 days out of 7 it's done this. What can we do to make that change? And another thing I'm also very keen on is making sure every patient has a treatment plan. And 99.9% of their lives are not spent in contact with healthcare professionals. They're at home. It's actually, they now have the data. What can they do to make sure they have the data? So, as I said, we've only had CGM funded this week in New Zealand. So one thing I wanted to make sure that everyone in our service had was a plan to correct hyperglycemia, remembering that most people are still on multiple daily injections of insulin and not on pump therapy. But then have that information how they can change their mealtime insulin and make those changes. Another thing as part of the treatment plan is when to check blood glucose levels, because it is marketed very much, or CGM is marketed very much as 100% replacement. I don't think that's entirely true. There are times when you definitely want to still recommend checking blood glucose levels, particularly if there is a mismatch between symptoms, either high or low blood glucose levels, and what the CGM shows. And also explaining why blood glucose levels may be different. And it's more than just the lag in the modern sensors is probably down to a few minutes at best between blood and interstitial glucose levels. But it's also around how, when we monitor and the standardization for our sensors, those differences. For example, our funded glucometer in New Zealand reads slightly higher from what venous glucose is, whereas our CGMs tend to read slightly lower than venous glucose. Both are right. Both are well within that 10% to venous glucose, but you will see that difference. We know the intra-assay variation too. So it's just about trying to get that message across and to go off what the trust the most, and most that is CGM. So here's just an example. I just Googled one in terms of a normal CGM trace. So you can see you will have a rise, after meals. That is completely normal. You often will, for people even not on insulin or sulfonylureas, dip into those threes overnight or other periods of the day. It's not significant. I'm sure it's going to redefine our normal range of glucose levels for most. In fact, many centres have already gone down to 3.5 millimole per litre for that lower limit of hypoglycemia. You'll also be very familiar, this is the diatribe, 42 factors that affect blood glucose levels, and really food and exercise, only being a few of them. So that is something to be aware of and for people to act around. I will have many people, for example, who will give themselves a bolus of insulin for their morning coffee. In fact, more often than not, just because of the rise in glucose levels, despite the fact there may be no milk or sugar in there. And this is diabetes team distress is one I think we should think of as well. And this is, you may see this in your practice as well. I'm sure you're doing this already, but I'd really encourage you to keep fighting for funding of CGM in India, other countries of Asia and Pacific where it's not funded as yet. It took us many, many years. In fact, one thing even though I'm very happy to be in India right now, I wanted to be in New Zealand for literally Tuesday was the first day. Yesterday was I've lost time travelling, but that was the first day of funding for CGM in New Zealand. So it's a momentous occasion. But with that, all of a sudden, It's not only patients and families that get all that information, it's the diabetes team as well, and in primary care, because they may be sharing much of the load in terms of the diabetes care. And all of a sudden, I don't have the time to look at 15 to 20 pages of reports. I don't know what this information means. What do I do with it? HbA1c was actually easier. I understood HbA1c. I knew what targets to look for. What am I doing with CGM? But I want to show you a way that I do a lot of teaching in terms of both primary and secondary care about how you can interpret CGM in less than 2 minutes. And it's really just having to know what to look for in doing so. So here's that guide. So the first step there's only 5 steps, is there enough data to make decisions on? Now, the international consensus for this is above 70%. And this is still really relevant when you've got intimately scanned CGM like the Freestyle Libre 1, which you do in India. So I still think you can make decisions if you've got the same part every day, but it's just making sure that you do, is that data there? We're lucky enough that we don't have the Freestyle Libre 1 anymore, but we... Yeah, exactly. Exactly right, and we've got the Libre 2 as our minimum model now, and that's real time. So it is. But when we had the Freestyle Libre 1, I had plenty of people that wore it but never scanned. They were just wearing it to keep the family happy. Yeah, it is the point. Yeah. It does. Yeah. But yeah. No, exactly. So you're looking at the targets. Now, our targets, for most, and once again, there are individualised targets, and sometimes we do, reduce these targets, particularly in the elderly population when we're dealing with adults. But it's above that 70% time and range. Time and tight target range is becoming more and more commonly used. That's greater than 50% between 3.9 to 7.8. It's also the same range we use during pregnancy. But we're aiming for greater than 70% in pregnancy. GMI is basically the calculated HbA1c, and once again, for most, we're using less than 7%. When you get out to 60 days of data, basically the GMI is a very accurate indicator of laboratory HbA1c. In fact, CGM's changing the way we work, and we realised how often we had limitations in our HbA1c, remembering that it's only as good as the hemoglobin when you're measuring the glycated hemoglobin. And I'm sure hopefully when you have everyone on CGM, we won't be measuring HbA1c that often anymore. So that's that second step. And the third step, you're asking yourself, are there any lows? That's that basic approach. And you're looking at, is it less than 4% in mild hypoglycemia, and ideally no episodes of significant hypoglycemia. And that's what you're aiming for. And taking that through, I'll take you through both Libre View and Clarity. The good news is they all look fairly similar in how you approach that. So that first step up here, how active is, or what's the sensor usage? And this is someone on the Libre 1 who was intermittently scanning, but not too bad at 65%. Here is you're now looking at, are they reaching their glycemic targets? The time and range, only 22%. And you can already see here, with 0% below range, before going no further, this person needs escalation of therapy. That from this is the very first screen that you get, and the GMI is compatible with that. So you can see HbA1c of 9.4%. As I said, 0% below range. So you now know moving forward what you need to do. Here it is on Clarity. This is real time, as you're discussing. So you've got 100% usage. They do have 76% time and range. So they're doing very well with an HbA1c of 6.8%, and also very minimal hypoglycemia. So they're reaching their targets, but you may also still look at de-escalating therapy to prevent the hypoglycemia. So that's the other way around as well. So we've done those first 3 basic steps, And the next step is looking at the ambulatory glucose profile. And this will show you the daily pattern of glucose levels. This will often contain all the information you need. So this is on the second page of your reports. You often need to go no further whatsoever, but then you're adjusting the information, or adjusting the management as required. And I think a useful approach is you're fixing hypoglycemia first, if that's relevant. You're then fixing the hyperglycemia. You can then check the daily patterns to make sure that what you're going to do is work. It's going to work and it's going to be safe. So here's what an ambulatory glucose profile looks like. I'm sorry if I'm teaching many of you to suck eggs, because I know that many of you will be very familiar with this. But basically, you've got from midnight to midnight on average day. You've got the median glucose profile in the dark line. You've got the 25th and 75th percentiles around that, and the 95th and 5th percentiles there. So that contains all the information that you need. This would be a very typical profile for many of my people with diabetes. Basically, you could arguably be on too much basal insulin and not enough prandial insulin across the day, and there are often many factors causing that. But here you can see, someone on a basal bolus regimen, you probably look at reducing their nighttime basal insulin and increasing their bolus insulin across the day. And you can look at the daily profiles down here. So the good thing is that the daily profiles in a mini version will come below the AGP. So, at least 95% of the time, I don't go past those first 2 pages. That's all I look at. And you can see which days are relevant, and we're working around that to get the best treatment. Here's just the highlighting, the periods of hypoglycemia as well as on the relevant days, and then working through around that. So moving on now to sensor adherence, because this is a new issue as well. It's not just being financially able to get the sensor, it's also making sure the sensor stays in. So here's a 15-year-old girl. She's using the Dexcom G7 with the Tandem and Control IQ algorithm. Her major issue is that the sensors are only lasting 1 to 2 days at best. So her overall sensor usage is only 30%. Even when she's got the sensors in, she's not always got connection. So her time and automation is 25% at best. So one thing about, and I know that you've only got a very few, probably people in India in particular, on automated insulin delivery, is that you can put almost everyone on automated insulin delivery. Whereas before, you may be nervous about non-sensor augmented pump therapy. That many of those fears can go away altogether when you get to automated insulin delivery, but that's relying on the sensor to be your safeguard and being in place. So if the sensor's not in place, then you do potentially have an issue. What she did is tried multiple adhesive products, had no real luck, and she actually wanted to go back to the G6 because even though it was bigger, she actually felt that stayed in better than the G7. Now think about how you'd manage this in your practice. So around how we prevent sensor detachment, and this is where, if you did have a choice of sensor, that may influence you as well. Because this is all common sense. This is nothing amazing about this, but trying to choose sites with reduced physical contact if you can. Now, Libre technically is only center approved for the outer arm, and that's where Dexcom and others can be useful. We have done studies where we've looked at the freestyle and other sites in the body, and it does seem to basically work equally well. I do encourage people, though, when they are using the Libre outside of the arm, to check blood glucose levels and just make sure that it does seem to be accurate, because it is technically off-label. Make sure the insertion technique's correct and they're actually using dry skin before inserting, so letting whatever products are put on, for example, it may just be an alcohol wipe, letting it dry before inserting. Making sure they take care with the sensor. Part of the reason why I was encouraging you to wear a sensor to know what your glucose levels do is also knowing what it's like to wear a sensor. And how to take off clothing, how to dry yourself getting out of the shower. I mean, it can take a wee bit getting used to. Also making sure that just quickly check the sensor every day. Is the adhesive, still adhering well? If not, I'll put that down. I may even put a bandage over it. So we have, it's probably cheaper here, but we have 100 rupee bandages, for example, at the supermarket. Pop that on. That will often do the job. And that's all you need. It doesn't have to be expensive products to keep CGM in. There are, though, if you are still having issues, it's rare that you need these, but there are other products as well that does make the skin more tacky or sticky, so the sensor will stay on there. Often, if you want to access these, going through the supplier is often your best bet in terms of doing so. Yep, that's a good point.
Because if the sweat collects,
Yep.
it gets full and messy, and a lot of these people will then say the sensor can't breathe. Whatever that it does make sense, but that's what they find. So I think we need to also encourage them not to put it on top. Just ordinary micropore tape, medical tape would be better than something like Tagaderm on top.
And it probably is different for every country as well, because I imagine wearing an over-adhesive in India is a lot different to wearing one in New Zealand. And so that sweating, absolutely right. And it's about doing what works for people. So it's being pragmatic, and because people will prefer, it comes down to patient preference at the end of the day, what works best for them. So in terms of skin reactions, because this is another potentially common issue, I don't know what it's like in India, for example, but I'll talk about that after this case. But we have a 14-year-old Māori boy, Indigenous people of New Zealand, is very high HbA1c, so 12%. He started the Freestyle Libre 1, wore it on the outer arm. Within the first day, started developing pain and a lot of itching, hated wearing it, was in tears, wanted it off straight away. For example, it actually looked more severe than that. I couldn't access his photo, but there's just an example of what it can be done. So severe skin reactions are rare, but it's still, up to a third of people can still report, skin reactions to sensors. Now, the Freestyle Libre 1 still, it's the acrylates in the sensors which are the major cause, of the irritant or allergic contact dermatitis. Sometimes it can be the adhesives themselves, and the patterns that you get can give you a clue to whether it's the sensor or the adhesive. But the good news is that the newer sensors have stopped using isobornyl acrylate. So the skin reactions with the newer sensors are far less than with the Libre 1. So hopefully it's another reason for getting it into your country. But it can be a major cause of distress and not using CGM. But the good news is that you can prevent skin reactions in most. We have a very atopic population in New Zealand with asthma and hay fever as well. So we do see a lot of skin reactions. So,
For the audience, I would like to emphasize that with little children, we can extend the sensor, right?
Yep.
We don't extend the sensor
No.
with the little ones because they get more skin reaction.
Yeah, no, it's a good point as well. So, and this is once again going back to basics, but it is trying to rotate injection sites and trying to use sites that are free of skin irritation already, and that may be a recent previous sensor site. And it may be as simple as rotating arms. Left arm one sensor, right arm the next sensor, just because these people have to live with diabetes their whole lives. So think about skin real estate as well, and trying to reduce that. Some people may need to shave to help reduce that irritation as well. We do advise not putting on lotions or oils within the preceding 12 hours of where you're going to insert that sensor. Obviously, they can use it wherever else they're going to, but just on that sensor site. Do wash hands before inserting the sensor and clean the area if you can. A lot will depend on access to alcohol wipes, for example. We're lucky in New Zealand that our sensors will come with alcohol wipes. I imagine that's probably not the case potentially in other countries. If you're getting skin reactions, there are barrier creams available which you can use, and often that will fix the skin reaction itself. One thing is that the barrier creams often make the skin more tacky as well, so that will also often help adherence issues. If that is still an issue, we often use a steroid nasal spray. So fluticasone, 1 to 2 sprays to the site, let it dry, wait for a minute, let it dry, and then insert the sensor, and that will probably fix at least 95% of skin reactions just there. You can still really get skin reactions despite that, and that's when I would encourage using or potentially trying a different sensor. So it may not be the same, between sensors or adhesives in particular. You may think about needing to get your dermatology colleagues on board if needed. You can do, for example, skin or patch testing to work out exactly what is the irritant, and then choosing a product which doesn't have that in. I have 2 people who also put on a special type of non-allergic tape before putting in the sensor. They then insert the sensor through the tape. That fixes the issues as well. So there are, I will have a few hundred people on CGM at least. In fact, within the service, I'd have over 1,200 adults as well, and basically everyone can use CGM. So, but it is often going through every step to get there in that process. So I thought I'd go through a couple of other sort of common scenarios or troubleshooting which may come up. The first one's compression lows. Because this is an issue. I've seen basically lots of inappropriate action taken on compression lows, sometimes reducing treatment when it didn't need to be reduced, and also vice versa as well. So with compression lows, what you should see is basically a very rapid decrease into hypoglycemia, and with a generally should be asymptomatic, and then a rapid increase back up without doing anything. If you do see just a very gradual development of hypoglycemia overnight, that is probably real. It's probably not compression, even though they may say, look, I was sleeping on it, I think it was a compression low. Please be suspicious. It was a very gradual onset, particularly if it's symptomatic, that was real, and adjust the management appropriately. But it is something which you will see, and people often panic about, particularly when alarms start going off in the middle of the night. Usually it's with sleeping, but it can be with other positioning as well. This really is a first world problem, but it is important in terms of making sure the phone's actually compatible with the device that you're using. And for example, with the impending funding of CGM this week, a whole lot of people in New Zealand went out and bought iPhone 16s, only to find out they're not compatible with the sensors. So, it is arguably wasted money, because just by default, the compatibility with phones and smartwatches will always lag behind the new models that come out from the companies. And even if you do automatic updates, that may actually lead to loss of compatibility. So it is about people being aware of what works and what doesn't. The supplier websites are usually very good at showing what devices will work and what won't work. But I think it's also useful for diabetes teams to be aware. I mean, more often than not, we're not technology experts, but we should be giving, you should be able to give advice, or at least point in the right direction to where people can get the information to make the choice. For example, with our funding that's just come out, we can now choose between 2 sensors. One will work with Fitbit, Samsung smartwatches, the other one won't. And so there's all these little nuances and differences there. But I think it would be really, I think it's great if the diabetes team can lead the way in CGM and not vice versa. And what I mean by that is, and this will be, as I mentioned earlier, different in every country, but many people can get CGM straight from the supplier and bypass the team, and as a result, they won't have all that necessary education or maximise the benefit from CGM. I believe CGM is much more than just a sensor itself. It's everything that goes with it. For example, when CGM came out, in Europe, had to be prescribed by the healthcare team. They couldn't access it any other way. I know that varies wherever you are, but I think if you can front load CGM with giving that information around, what's normal, what is the expectations, what are my targets, what was great about time and range is it changes every week. Whereas people had to wait 3 months before they see the full change in HbA1c. So it's really powerful to use that week-to-week change. You can do things a whole lot more quickly than waiting 3 months. But setting up people and their families to do that, and not just relying on us or doing it themselves from YouTube systems. Just quickly, finally, switching between CGM systems. This is likely to become increasingly popular. One great thing which has been happening now and hopefully will filter down to countries that don't have all the models, but there's increased operability with CGM in different pumps. So we only have 2 funded pumps now, and for example, in New Zealand, the Tandem and Ipso pump, but it will work with both funded sensors, which is the Freestyle Libre 3 Plus and the Dexcom G6 or G7. So previously, we only had, there's 1 pump, 1 sensor, that was it. Now we're seeing the increasing, can potentially work with every sensor, and even at the higher level, we're now seeing Medtronic, for example, talking with Abbott about how we can start pairing that. So we're getting closer to our dream of having a patient being able to choose their sensor, choose their pump, and then choose their algorithm. That was always been the dream. We are seeing newer models become available. For example, this once again in New Zealand, I know it's similar in Australia, but we've now got the Lynx ADIX models of CGM, for example, that arguably they may not be as accurate, but what has been great is it's starting putting competition on the bigger players, and the prices are starting to plummet. It's basically what the consumer needs for competition. We're seeing a lot more standalone models, and I think definitely in many countries and across Asia and Pacific, getting funded automated insulin delivery is still a long time away in the future. But we can get the CGM, and these cheaper models may actually allow us. Arguably CGM does a lot more than a pump by itself. When the two together, it's great, but we'd always love to have CGM first. Hopefully that the funding comes around with that. I know that many of the companies are also good at doing free trials for patients and not. You could look at it as an advertising gimmick, but it's about, in that 2 weeks, can I make the changes that I need to do to get things moving in the right direction? We're also seeing a lot more data now about ideally CGM should be started from diagnosis, but once again, we're seeing those differences between the haves and the have-nots, and how can we reduce that? How can we get funding? Yep, sorry.
So I would have a tip there. When the child is diagnosed and is very sick,
Yep.
and we have payments out of pocket, right? Thank you. That's the time to buy the CGM, because that's the time when they're traumatized enough to spend the money. And the second thing for us as a country is that we still have the Libre sensor reader, and that has a port for ketones. So now, right at the time of diagnosis, I have a ketone meter in this family's house, and I don't have to worry about them running around for the ketone testing when they're sick.
Yeah.
So I think what happens is, once you've gotten used to a week or so of SMBG or doing something which is less complicated, then you get into trouble, because then there's a huge amount of resistance to start something new. But at the beginning, if you start with the Libre at least, so you've got a ketone meter, you've got a reader in the house, and then they can use it regularly or intermittently, rather than mull over whether they can use it at all or not.
Yeah, I think it's a really good point, because I think it doesn't matter. I've always found, it could be 10, 15 years in the future, but people always remember at diagnosis. And this is my biggest plea as being an adolescent endocrinologist. It's what the messages that the PEDS team gives, is it literally sticks with them for their whole life. And if you can, right from the first day, and that includes around monitoring and checking, but also it's around insulin and food too. It's part of that transition process. Is consistent messaging is so important, and right from day one, as you pointed out.
Professor Ryan, may I remind that this is last 11 or 12 minutes, including the discussion time.
Right, okay, sorry. I'll go through fast, Ganesh. Basically, it's empowering people to choose the CGM that suits them the best. There are differences. You may not have the ability to choose between systems and only having what's available in your country, but it's about personal preference. There are differences which do suit people best, and I've already spoken about, we should be that main source of information, at least putting them in the right direction for where they can get that information to make that best choice for them. That is the time for discussion. Thanks.
The floor is open for discussion. I would request the questions to be brief or comments to be brief, and one per person till the time we exhaust all the people in the question line. Dr. Leena, please.
Thank you for the wonderful talk.
If I am not aware of your name, please introduce your name and institute before you put your question.
Leena from Hyderabad, Pediatric Endo. So is there any difference in the different sites that you apply the CGM, whether it is arms or abdomen or in the terms of sensitivity or any errors? Or like a lot of people don't want arms because it shows.
Yep.
So.
Yeah, I guess technically speaking, the Libre is only approved for the arm. So if you do differ away from that, there may be differences. And the studies that we've done, and I must admit, the studies that we've done have been very small. They've been like ends of 20. So this is not, I wouldn't hold my word for it, but it's been found that chest, abdomen, legs have worked absolutely fine. But I would encourage people to check their blood glucose levels if they are wearing it at sites not on the arm for the Libre, and just basically making sure that it's safe and correct. The other thing is, if we're lucky enough to have a choice of sensors, that they may choose a Dexcom or Guardian instead of choosing the Libre because they don't want to wear it on their arms. And that's how to approach that.
Yes.
Yeah, wonderful talk. Thank you. I have one question. So the storage conditions, do they matter as far as the Libre is concerned? And are we supposed to store those CGMs in air condition? Because in India, we get certain months in the year that are quite hot.
And I'll be honest, I'm not aware of the actual upper limit. We don't have that issue. We're very lucky, but it probably does. And within, cold won't be an issue for you, but even northern India it won't be an issue. But the upper limit, if it's hitting 50 degrees, I think air conditioning ideally. They do have a long shelf life. We are lucky from that point of view, but I would always follow the recommendations from the supplier for that.
With the
Professor
young
Preeti.
toddlers, there's an issue that they pull it out. We have had such issues from parents that within a day or two. So how do you overcome that?
That's why I do adults. I think it's choosing a site that probably works best, if possible. Another one will be you thinking about what products can I use to increase adhesion, and yeah.
And then I challenge you to have a 2-year-old get that 3 layers of tape off him.
But it's what you end up doing. Or you may choose to, potentially put it on the sites on, the back if they can't reach around there, or whatever's practical works best.
It doesn't matter.
No.
So I have a question.
Yep.
So many of the Indian families use a professional version of Libre with third-party applications like Glimp or Meow Meow or Bluecon or some add-on devices. There are two challenges. One is about the accuracy of these third-party applications in terms of the glucose record, and secondly, the output from this data, I find it extremely difficult to interpret. So I kind of prefer the output from the Libre AGP.
Yeah, and that's a good point, because that varies around the world too, in terms of apps aren't regulated in many countries. They could even tell you to take 10 units of insulin, for example, and we've got no control over that. I think encouraging to use that recommended app is useful. You can even compare as well between the two. I always try and encourage that. At the same time, many people will, and like glucose, our main platform, for example, for looking at data in our clinic. People use night scale. There's a whole lot of various options. I think it's just people being aware that there may be some inaccuracy in that data, and that it may be basically doing it potentially at their own risk. It would encourage you to use that paired app. And it's not just for accuracy; it's also for connectivity and getting the most out of the alarms, etc. So there are other benefits to just not doing that. At the same time, I think it's also important that we do what patients want. And if they're adamant they're going to use the app, that we find a way around that to interpret that data and still use that. But it's about that discussion, having that with that family.
Praveen, please. Dr. Praveen. Mike.
My question is, during an episode of hypoglycemia and the correction of that hypoglycemia, can we go just by the CGM, or is it better to always go by the...
Yeah, so this is where you will find that the newer sensors are approved for basically treating hypoglycemia, but the older sensors aren't. And I take a very common sense approach to this. If they're symptomatic of hypoglycemia and it's reading low, to treat. If they're not symptomatic and it's reading low, I would recommend doing a blood glucose level to check, because you may prevent over-treatment of hypoglycemia. And that's the approach. Technically speaking, if you've got the older models, are still supposed to check their blood glucose levels first. So this is something where it does depend on what CGM product that you're using. But I think if they're symptomatic of hypoglycemia, it reads low, saving time and treating is also a useful approach.
Well, as a chairperson, I'm allowed one extra question. This is my own rule. Any comment on intermittent usage of CGM?
Yeah, and I think
and
that's
its benefits?
realistically, that's when you've got in a non-funded country, that's what people can afford. There's still very good data showing intermittent use is beneficial, and all the major international guidelines still recommend intermittent use if continuous use isn't affordable. So I do encourage that, as many of our families can't afford, well, until now, could not afford continuous use. But try and do, I think it's what really useful is timing that 2 weeks of sensor use to making the changes that you need to change. The other thing which is I strongly encourage is getting people to do what they normally do during that 2 weeks. Because often what people do, they wear the sensor, all of a sudden they see their glucose levels sky high, they change their behaviour completely, you make changes, and then when they go back to normal life, it's just chaos. So I try and say, do what you're normally going to do for that 2 weeks, but give me the data so I can make those changes that are needed.
Yes.
I have a small question.
Yep.
Do you recommend
Last two questions after
soaking in of the sensor? If yes, then soaking in of the sensor?
If you can afford it, yes. So for people that aren't aware, what soaking is basically you warm up the sensor before you start using it.
So the way we understand soaking is you put the sensor about 12 hours before.
Before starting it.
Let the local inflammation settle down.
Yeah,
and
exactly. Yep.
activate it later.
Yep. It's the same thing I was going to say essentially, but because you will find if you're going to find a period where it is potentially inaccurate, it's going to be those first few hours of sensor insertion. So if you can, this is where if you can afford it, often you will insert, for that first 12 hours, for example, and then start using it. But I'll be honest, many people can't afford doing that, and so that they can't soak.
Professor Anna?
Just a doubt. Is there a level of glucose below which the CGM is not sensitive in picking up hypoglycemia?
It does become more inaccurate in the lower glucose ranges, so they will read less than. I'm not aware of what the less than limit is, but just be aware that is the greatest period or the greatest range of inaccuracy is in that hypoglycemia range, and that is often where you need to correlate with blood glucose levels before making that decision.
It'll be good to do a blood glucose level because of that.
That is the period, yes, that you would be checking, particularly they're asymptomatic, and say that it's reading 2, well, that's not, there's something clearly not right there.
But it helps because it also reassures them that the sense is working well.
Yeah, if that's useful from that point of view as well.
So,
Wayne.
Just a very quick comment, Ryan, about temperature and CGMs. Libre 2 and 3 starts becoming inaccurate at 45 degrees. So that's, I guess, the middle of summer in Delhi for a few days.
Yeah.
And eventually they'll read errors, but before that, they start sliding in terms of accuracy. So
Yeah, thanks, Wayne.
So I think we can.
One more minute.
Yep.
One way to avoid distress in the beginning, sorry Ganesh, is that you have to counsel the parents, because one reason why adolescents refuse is they've had a little snack in the middle and mom gets to know about it even later. I mean, she may not be able to phone immediately, but so we've got to tell them that it's okay for the child to cheat a little bit, and you mustn't get hysterical each time there's a blip, because if she has a chocolate, it's not the end of the world.
Exactly right. That's that lifestyle ruin diabetes and setting the expectations that you spoke
Before
about.
the sensor.
Oh, definitely. And it's always good if you can preload CGM before they put the sensor in themselves. And that case was just an example of where gone straight to the supplier, put it in the sensor, and that's where the issues arise.
I think we are out of time now,
Yeah.
and I'm sure that the audience doesn't need more convincing about how useful the CGM is. What is more interesting is using it right from beginning seems to have long-term impacts on the diabetes management and outcomes of the child. Thank you very much,
Thank you.
Professor Paul, and thank you, audience, for a great interaction.